First of all, thanks to uh, Mrunal Joshi sir for inviting this examination talk. So today I will be talking on the examination of ankle and foot joint. I think every one of us in our OPD are routinely doing the examination of ankle and foot joint. Okay, there are lots of tests which we can't apply in OPD setting. So we should be very specific as per the palpation, as per the surface anatomy, which structure need to be palpated, and we can get the fair idea about which is the main pain generator. Okay, in every clinical examination, we need to find out the pain generator, which is the main pain generators in ankle and foot examination, and how we can deal with it properly. And this clinical examination is the extension of history taking. You must to know about I hope that every one of you know the history taking properly. So it is extension of clinical examination, and nowadays there is MRI, ultrasound, what we are doing, that is extension of our clinical examination. The ankle and foot joint is a synovial hinge joint, and ankle mortise, which is a basically socket which is formed by the extension of medial malleolus and the lateral malleolus beyond the ankle joint, and it is creating a cup-like structure which is useful for the snug fitting of talus and which provide the proper stability to the ankle joint. Again, the ankle joint, there is a lot of ligaments which helps in the stability for the ankle joint. The basic anatomy, like for our routine examination and for clinical assessment, we divide the foot into the three parts. First is the hind foot, which is comprises of talus and calcaneum. Midfoot, basically all tarsals and metatarsals bone, basically navicular bone, then cuboid, three cuneiforms, and metatarsal. And forefoot is majorly comprises of phalanges. So while again considering for the palpation, we need to palpate each area. Surface anatomy, which is very important. In this picture, you can see we will start from the lateral aspect, where you can see this. So this one is a lateral malleolus. Okay. So from the lateral side, just start your palpation from back side to anterior or anterior to posterior. Okay. So we'll start from the lateral malleolus. Okay. And you start palpation, and as per palpation, if there is tenderness, we can consider of the different types of pathologies, like is there any fracture of lateral malleolus or fibular fracture. You start from the proximal to distal or distal to proximal. Again, if this is the ATFL ligament, this is the calcaneofibular ligament. Again, there will be the one ligament, that is posterior talofibular ligament. This is the tendoachilles. Just anterior to that, this will be basically the tenderness for the peroneal tendinitis. Okay, these are the peroneal tendons. We can get the idea about if it is this painful, this part. This is basically the base of fifth metatarsal. We can get idea about it may be the possibility of insertional tendinitis of the peroneus brevis, or if you get a pain this area, we can get the possibilities of peroneal tendinitis. In the next picture, we can see this is the medial malleolus. Posterior to that, there are the three different tendons. Tibialis posterior, which is the commonest tendon involved in the tenosynovitis in the foot. Again, it is which is responsible for maintaining the longitudinal arches of the foot. If you get the patient, which is very frequently we are getting in the OPD, patient comes with the flat foot, planovalgoid foot, to always assess for the tibialis posterior function. Then next will be the flexor digitorum longus. Okay, and posterior to that FHL. The next tendon, which usually involved in the tenosynovitis, is the FHL. But as compared to the tibialis posterior, the frequency is less. Posterior to that, just palpate for the tibial artery, and the laterally there will be again this tendoachilles. This will be the part for the plantar fascia. Medial calcaneal tuberosity you can palpate. This is for the bunion formation. or bursal formation when you get a hallus valgus type of deformity. So this is the area where you should palpate for the bunion. You can easily visualize also, and this is the navicular bone. It is commonly seen in the frequent runner who are usually running, like Henry sir here, he is I think marathon runner. So if you get the patient of and runner, sports person, if you get the tenderness, this area, we can think of the navicular stress fracture or accessory navicular. Then next again the posterior aspect, tendoachilles, this is the bursa. This will if it is the tenderness just superficial to the tendoachilles, it is retroachilles bursa, and anterior to the Achilles tendon, retrocalcaneal bursa. One more bursa, this is the subtalar bursa, subcalcaneal bursa. This we can get this part. And if you get a pain in the center of heel, that we can consider for the central heel pad syndrome. Basically, it may be due to the necrosis of heel pad. Usually happens when we inject, commonly we are injecting for the plantar fascia injection. Okay. Initially, we are injecting landmark guided, but most of the time, basically what happened, our steroid injection will go into the fat. If you are doing routinely, sometimes we inject for 2-3 times, the patient may get a fat pad necrosis. And this is the anterior section where you can get different tendons like tibialis anterior tendon, then extensor hallucis longus tendon, extradigital longus, and between these two parts, basically, between the first and second metatarsal and between the EHL and EDL tendon, we get a pulsation for the dorsalis pedis arteries, which is again very essential for the foot and ankle examination, because neurovascular examination is important, which is a part of routine examination. Deltoid ligament complex. This is very important ligament. Again, there is always a mesh of so many ligaments in the ankle joint. So for the easier section, this deltoid ligament, there are the 6 parts. 2 is a deeper part and 2 in the superficial part. So deeper part, this one is a deeper part, this blue one, blue and sky blue like, so the deeper part. The deeper part is formed by the deep part of posterior tibiotalar and anterior tibiotalar. Superficial part, there are the again 4 different types of ligament. Superficial part of posterior tibiotalar, tibiocalcaneal ligament, tibiospring ligament, and talonavicular ligament. You can see this ligament which is coming from the sustentacular tali to navicular. This is the spring ligament and this is talospring ligament, tibiospring ligament coming from the tibia to insertion over the spring ligament. Then next is on lateral side, we have the lateral ligament complex. Again, there are so many ligaments. First and commonest most is the ATFL. Okay, anterior talofibular ligament. It is having the 2 different bands. You can see in the picture. One is the superficial, and other one is a deep band, which we can easily assess on the ultrasound. Then next one is this will be the talonavicular ligament. Okay, posterior talo, which is not seen in the picture. Posterior talofibular ligament. Then anterior tibiofibular ligament, calcaneofibular ligament, talonavicular ligament, dorsal calcaneocuboid ligament, and this bifurcate ligament. Okay, it again has 2 parts. One is the straight and one is the oblique part. Anterior part, already we have seen, these are the main tendons which we can consider for the palpation and clinical for muscular examination also. Laterally also we have seen it. Examination of ankle foot. Usually examination of ankle and foot, or almost all joint basically it is same. It is comprises of inspection, palpation, range of motion, power assessment, special test, and detailed neurovascular examination. And basically, while doing the examination of ankle and foot, you have to examine the knee also, knee and spine, because most of the time the pain is coming from the spine or referred pain. So need to examine the spine also. The prerequisite for the ankle and foot examination is, first is the consent of the patient which is required, and explain the patient about what you are going to do with the patients and what structure you are going to examine. Ensure the privacy of the patient, adequate exposure, remove socks, shoes, and expose till the knee. Usually inspection and palpation should be done from the front side, back side, and lateral. It should be done in the both weight bearing and not weight bearing position. And before examining the whole ankle joint, as we have discussed in the previous slide, we should know about the surface anatomy. According to that, we can palpate exactly which area is painful, which area is non-painful. Gait analysis. The ankle examination should start from when the patient enter your OPD, you should start from the gait analysis. And again, the gait analysis should be done from front side, back side, and side. Usually what we see in the gait analysis, stance phase and swing phase. And again, in the stance phase, initial contact of the foot, which is important, then loading response, then mid-stance phase, how is the swing phase, whether the patient is walking with the antalgic gait or not. If the patient is having the antalgic gait, there will be the reduction of stance phase, there will be the reduction of step length and stride length also. And one more important thing is look about the foot progression angle. Any of you can tell about what is the foot progression angle? Anyone? Saran, I think Saran can tell. Okay. When we are walking, there should be the one imaginary line. Usually, if I am walking on this, so this is the one line, and other line should be to the center of foot. Okay. Usually, there is about 5 degrees of external rotation of foot while walking. If it is more, if the foot is in the varus or valgus, so we can get idea about the deformity also by foot progression angle, whether it is 0 or whether it is excessive valgus or excessive varus. And don't forget about the footwear examination. This post gait analysis, just do the footwear examination of the patient. So we can get idea about which is the loading area or which is unloading area. Okay, by looking at the plantar's aspect or sole part of the foot. Usually the normal tearing and wear happens at the center of the heel and lateral aspect of the heel. If there is a deformity like equine deformity, the patient will load more weight on the forefoot. The forefoot area will be more teared. In calcaneum deformity, heel part will be more tearing. Over pronated foot, the medial border of foot will be more torn. In the severe pronation of foot, along with this medial border of heel, means whole border will be teared. In supinated foot, lateral border of forefoot will be teared. So it make actually good habit to examine the patient footwear also. Inspection, what usually we see the attitude of the foot, alignment of the foot, shape and symmetry, deformities, different deformities, arches of the foot, swelling and scar mark. And again, examination should be done in the standing and weight bearing. In the AP view, we usually look for the weight bearing, whether the weight bearing is symmetrical or unsymmetrical. If there is in this painful structure, the patient will bear less foot on the involved side. The position of the foot, supination and hyperpronation. Any one of you actually tell me about what are the different component of supinated foot? These are the common terminology which used in the examination: supination and pronation. Supinated foot, pronated foot.
In supination, it will be eversion of the subtalar joint and abduction of the forefoot and eversion and dorsiflexion. Plantar flexion.
Okay, plantar flexion, then
Abduction of the forefoot, plantar flexion, and eversion of the subtalar joint.
inversion.
Inversion of the subtalar joint.
And hyperpronated foot?
Adduction and dorsiflexion and eversion of the subtalar joint.
Okay, thank you. Again, ask the patient to walk on the heel and forefoot. Okay, walking on the heel can give us idea about the which muscle? Walking on the heel. Dorsiflexors basically, whether dorsiflexors are properly functioning or not. And forefoot, plantar flexors. Whether the patient is using any stick or cane. Okay, if the patient use stick on the contralateral side, so we can reduce the weight basically. Again, it can give the idea whether the patient's part is, which part is or which leg is involved. Check the toes, different types of deformity or any color discoloration in the toes or not. And hip and knee examination, which is again the important part in the ankle and foot examination. Standing and weight bearing in the lateral view. Lateral view usually observe for the longitudinal arches. Okay. What are the different arch deformities?
Pes cavus, pes planus.
Pes cavus, plus rocker bottom foot. What is a rocker bottom foot? Rocker bottom foot. Loss of basically arch, and foot will be in the dorsiflexion little bit of. Standing and weight bearing in the posterior view. From posterior aspect, we'll see the bulk of the calf muscle. Okay. Whether there is any hypertrophy or atrophy of the muscle, which we can get a different clinical condition like suppose DMD patient, you can get easily hypertrophy of the calf, pseudo hypertrophy. Whether the patient is sports person or any type of entrapment neuropathy like sciatic nerve injury hai, you can get the wasting of hamstring, calf muscle. Again, look for the Achilles tendon, whether it is vertical or deviated. Observe the calcaneum shape, callosities and position of the calcaneum, that is also important, and observe the malleolus also. So from the posterior side, anterior side, lateral side, we need to examine the different types of deformities. When we look the patient from the back side, so usually there is a 5 degree of valgus deformity, but that is not normal. And we can see almost 1.5 to 2 toes from the back side. If you are basically saying the more than 2 toes, that is too many toe signs, there is something problematic in the foot. Okay. From front, we can see the bunion formation. If there is hallux valgus deformity because of friction or footwear, a patient can develop the bursa, splaying of the toes, then forefoot valgus or varus deformity. What is valgus varus? Any one of you can tell. It should be more of interactive. There are the lot of good video available on the YouTube. Okay, you can go and directly learn the examination from the YouTube. Then hallux valgus, varus deformity. What is difference between the clawing hammer and mallet toe? Very important and common question in the exam. You can tell. What is a claw toe? What is a clawing toe? You can see this picture and you can just tell me. What is claw toe, what is hammer toe, and what is mallet toe? You can see in the picture, in the clawing, there is a hyperextension at MTP joint and flexion at PIP and DIP joint. Okay. In the hammer toe, just like hammer, you consider hammer, there is again extension at the MTP joint, okay, flexion at the PIP joint and extension at the DIP joint, just like hammer. In the mallet toe, there is neutral basically at the MTP and there will be the flexion at the DIP joint. Okay. And these are arches from side. We'll see the arches, whether there is a cavus deformity or flat foot or rocker bottom foot. And don't forget about the examination of sole also. So we can get the idea about the sole, which is weight bearing area while walking, and callosities, different types of callosities, and particular which is a weight bearing area or which part of the foot is bearing the more weight, that part will develop the more callosities. In palpation, usually in palpation, we see the temperature with the dorsum of the hand, always compare with the other side also. Then joints, in joints, usually we palpate with the ankle joint, TMT joint, IP joint, and decide the area of tenderness as per the surface anatomy. Arches, whether it is fixed or flexible, swelling, edema, range of motion, then stiffness, instability, special test, and neurovascular examination. Palpation, usually we see the temperature, then pulsation, as I said in my previous slide, that dorsalis pallidis pulsation and posterior tibial pulsation, whether it is feeble or normal. Then sensation of the foot, palpation of each aspect as per the surface anatomy. These are the basically typical pain spots in the angle where we can get the fair idea about which part is painful. So what are the possibilities of the different types of DDs. In the part 1, okay, this is anterolateral aspect of the ankle. The possibilities of lateral ankle sprain, again the history is very important. Then second is lateral ankle fracture, possibly if it is higher and longitudinal in the orientation. Then medial aspect, we can see the medial ankle sprain, and above the ankle joint we can get the syndesmotic injury, or we call it as the high ankle sprain. Anterior impingement, usually we forget about the what is anterior impingement. Again it happens into the runner, okay, who is daily running, or maybe the possibility of anterior impingement because of, also in the old age also, the anterior impingement may be because of osteophytes or synovial hypertrophy, or maybe because of the fat impingement. Then peroneal tendinitis, tibial posterior tendinitis, tibialis anterior tendinitis, navicular stretch fracture, cartilage lesion of the talus, which happens into the, again, chronic runner. The pain will be on the anterior aspect of the knee. And posterior impingement, which is at the location of tarsal tunnel, posterior to the medial malleolus. But the tenderness will be deeper. Goniometry, which used for the measurement of the different range of motions. The range of motion in the ankle joint, the common range available, which is the dorsiflexion, it will be the 0 to 20 degree, plantar flexion 0 to 50 degrees, substellar joint, inversion and eversion. Inversion will be the 0 to 30 degree, eversion 0 to 25 degrees, great toe, dorsiflexion 70 to 90 degree, plantar flexion 35 to 50 degrees, and other MTP joints permit the 40 degree of dorsiflexion and almost same 40 degree of plantar flexion. You can see in the picture goniometry. One is a mobile arm and other one is a stationary arm. You should know about the how to do the measurement of the each joints. Ankle plantar flexion. This is inversion and eversion. How to basically measure the purely inversion and eversion range of motion? Which movement we should block? By doing the dorsiflexion, we can block the true movement at the ankle joint, and we can measure the exact, the location, basically the range of motion, inversion and eversion at the subtalar joint. Again, the power assessment, tibialis anterior, tibialis posterior, peroneus longus, peroneus brevis and tendo achillis. Power assessment also important, how to do the exclusive power assessment for the tibialis anterior. Just little bit dorsiflexion, inversion, and you can see the basically the prominence of tibialis anterior. The special test. One is the Hopkins test, which usually used in the case of if you are suspecting of the high ankle sprain or tibiofibular syndesmotic injury. We just compress the fibula against the tibia or the mid of the calf. The patient can get the tenderness just anterior or above the ankle joint. You can suspect of the syndesmotic injury. Again, you can confirm with the different types of imaging also. Coleman's block test. This is usually used for the whether the deformity is flexible or not. Okay, if you get the patient with the valgus, calcaneal valgus deformity. Now actually this test help in the making the decision whether the patient has to go for the surgical correction or orthotic management. In this test, ask the patient to stand on the block, which is actually 2 to 4 centimeter thickness. Ask him to stand on the with the support of hind foot and forefoot. Sorry, and first ray will be unsupported. If the varus deformity is getting corrected on standing, means the deformity is flexible. Hind foot deformity is flexible. Okay, the heel is coming from varus position to neutral or valgus position, 5 degree. This part, you have to look for this part. If it is correcting, the deformity is flexible. So we can use the orthosis for the management. If the deformity is fixed, if it is not correcting, then we have to think of the referring the patient for the surgical correction, or we can do in the PMR department. Third will be the Thompson test, which we use for the, if you are suspecting of the tendo-Achilles rupture, just palpate any defect is there or not and just compress for the calf. Normally we can see the plantar flexion of the foot. If there is a complete rupture, the plantar flexion will be absent.
Then after.
The anterior drawer test, which is used for the assessment of the ATFL. Just you can do it in the again the lying down position or sitting position also. Firmly grab the lower part of the lower leg, okay, and just cuffed around the calcaneum and just little bit do the translation movement at the ankle joint to assess for the ATFL. It can be positive in the ATFL injury, or if the patient is having the ligamentous laxity, we can get the positive anterior drawer test. Then talus tilt test. It is usually done for the lateral ligament complex. If the tilt is less than 15 degree, we can consider of ATFL. If it is more in the range 15 to 30 degree, you can consider of ATFL and calcaneofibular ligament. If it is more than 30 degree, means whole lateral ligament complex is injured. Dimple sign, again used for the ATFL rupture. So when we do the Taylor test, you can get the bulge or dimple sign, basically not bulge, dimple just anterior-inferior to the lateral malleolus. So we can get about the fair idea of whether the ATFL is injured or not. Then Kliger's external rotation test, which is for the medial ligament complex. Just do the opposite of the ATFL test. Okay, just try to externally rotate the foot and you can get about the idea about the whether the deltoid ligament injured or not. Of course, the history taking again important. Whether your foot was externally rotated or while doing the sports activity. The Morton test. The Morton test usually we do for the Morton's neuroma. Just do the compression of the metatarsal head. We can get whether the patient is we are provocating the same type of pattern or not. There is again a lot of confusion whether the Morton's neuroma, whether it is purely neuroma or not, or some says it is entrapment neuropathy, some says basically it is neurobursal complex, or some says it is purely true neuroma. So that is actually the subject of research. We can do it whether it is true neuroma or, but there is a lot of cases we have seen Usually there is a bursal complex. It is usually neurobursal complex. A wind glass test to check for the plantar fasciitis pain. Again, common condition. Just stabilize the ankle and distal leg. Passively dorsiflex. We can provocate the same pain in the patient. If it is positive, the possibility think of plantar fasciitis along with the tenderness. Then muscle isolation, ankle plantar flexors. The common muscles are gastrocnemius and soleus. Ankle dorsiflexions and inversion, tibialis anterior. This is very important for checking the power. Foot inversion, which is mainly caused by the tibialis posterior. Foot eversion with the plantar flexion, peroneus longus and brevis. Foot eversion with the dorsiflexion, peroneus tertius, extensor digitorum longus. So these are the muscles which are surrounding the ankle joint. So you need to know the details of common differential diagnosis. I will just read out the. Never forget about the patient is coming to you with the chronic anterior pain. So think about the anterior ankle pain impingement basically. Anterior ankle impingement. This is posterior ankle impingement. You can just provocate the pain by basically flexing the foot. The possibilities of like in the posterior impingement, you can see you can get a accessory bone or osteophytes, or there is a one condition like a beak-like talar structure. If there is a elongament of talus, so we can get impingement in the posterior aspect. If the patient get a pain in the lateral aspect of ankle, we can think of peroneal tendinitis, then ATFL sprain, tear, sinus tarsi syndrome, then osteochondritis dissecans. In the medial ankle pain, think about the tibialis posterior tendinopathy, FHL tendinopathy, then medial calcaneal nerve entrapment, stress fracture, tarsal tunnel syndrome, referred pain from the lumbar spine, complications of the acute ankle injuries, accessory navicular bone, and osteochondritis dissecans. In the posterior ankle, again there can be the possibilities of Achilles tendinopathy, retrocalcaneal bursa, subcalcaneal bursa, or retro-Achilles bursa, plantaris tendinopathy, Siever's disease, or referred pain from the lumbar spine, and posterior, basically osteochondritis dissecans of the posterior medial talus. Differential diagnosis for the heel pain, plantar fasciitis, subcalcaneal bursitis, painful heel pad syndrome, that is heel contusion, post-injury or in the post-injection, calcaneal stress fracture or calcaneal osteomyelitis. So there is a long list of basically different types of clinical condition we can think of as per the surface area. Okay, thank you.
You know that ligaments of the ankle are so strong, and even we get so many ATFL injuries, sprains, or tears. So how do you are going to address whether the intervention is necessary or only with the without any needle interventions? Can we go with only exercises or any regenerative
Depending
therapy?
on the basically the patient symptoms and sign. Again, in the initial phase, suppose how the severity of activities basically after the activities the patient got injury, and the clinical examination, it depends on the grading of the ATFL, whether it is grade 1, grade 2 or grade 3. In initial phase, even on the ultrasound also, it is difficult to visualize because of the inflammation and effusion. So initial phase, we can just stabilize the ankle and do the conservative management along with the ice compression or anything medication we can use. After 10 to 15 days, we can go for the ultrasound or MRI, which one is comfortable for you, and then can plan according to the patient is relieving pain or not. We can plan for the regenerative. Initially, we were giving the regenerative basically PRP in the chronic pain. Okay, along with the rehab sessions will continue. But nowadays, there are the few RCTs and good study are available. The people are injecting the PRP in the acute condition. Means post-injury, if you get a patient after 2 to 3 days also, or within a week. They are injecting the PRP, target-oriented PRP, under ultrasound guidance, and they are putting the casting or stabilization of foot. So these are also doing.
Any mode of prolotherapy in this
You
ligament?
can do it. No issue. Just keep your concentration 15% to 20, near about 20%, and do the stabilization of foot is very important. Don't ask to do the lot of activities.
Thank you so much.
Yes, thank you.